I'm Smita Bhatia. I'm a pediatric oncologist by training. I'm also an epidemiologist. And at the University of Alabama at Birmingham in the School of Medicine, I'm directing a program called the Institute of Cancer Outcomes and Survivorship. And my charge is essentially to establish a research program as well as a clinical program, which is focused on outcomes amongst cancer survivors across the entire trajectory of age. I want to start by saying that our cancer survivors are a very much critical population in the whole trajectory from diagnosis of cancer through their life. The cancer survivorship represents a very critical phase. The number of cancer survivors is growing at the rate of about 2% every year. We will, by about 2022, have 18 million cancer survivors. We and others have shown in our research studies that our cancer survivors are a vulnerable population. When they are completed their treatment, when they are done with all the active chemotherapy and radiation that they receive and are discharged from their oncology setting, it becomes clear to us that if we follow them long term, that they have a very high burden of chronic health conditions, which we call morbidity. Quite often you can link it back to the treatment that they'd received. So you can link it back to chemotherapy, you can link it back to radiation, sometimes you can link it back to surgery that they were treated for. And because of the fact that they are discharged from the oncology setting, this is not picked up by the oncologists, and very often in the community setting by the family practitioners, by the internists who are not seeing so many cancer survivors at a time. It is not in the forefront in terms of their understanding, in terms of their knowledge base, in terms of their experience of what they should anticipate. So cancer survivorship, cancer survivors, their care lifelong is an issue which I have taken the charge of here at UAB. In order to do that cancer survivorship, in order to provide the most perfect, the most comprehensive long-term care to our survivors, we need care plans. And so then the question comes up, what are care plans? Care plans are essentially a summary of all the treatment that the patients received for their particular cancer. And then what kind of morbidities we anticipate after they've received that care. And then how should we be taking care of these patients, knowing that they're at risk for these morbidities. So laying out some kind of a roadmap for our cancer survivors for life. That's what a care plan is. And that's what I would like to do for all our cancer survivors who are coming to the University of Alabama at Birmingham, no matter what diagnosis they have, no matter what their age is, from here on. Again, research studies where we followed large cohorts of our cancer survivors who've given so willingly of themselves. When we followed these large cohorts of patients for decades, what we found is that we can very clearly link certain what we call late effects. And why do we call them late effects? Because they occur many, many, many years after the completion of treatment. But we can link these late effects back to the treatment that the patients received. So I'll give you a few examples of these. For example, when we follow our childhood cancer survivors, what we're finding is that if they've received, girls, if they've received radiation to the chest around puberty for a diagnosis such as lymphoma, where the lymph nodes are affected, we find that there's an increased risk of breast cancer. This increased risk of breast cancer occurs at a much younger age than would be anticipated in the general population. So these girls are developing breast cancer at age 30 and 40, whereas in the general population you'd be anticipating it at age 60. If you give radiation to the lungs, there's a risk of scarring of the lungs or lung fibrosis and decreased lung function. you give radiation to the brain for a brain tumor or leukemia, there's an increased risk of what we call cognitive impairments. So school performance drops, or if they're people who've received radiation when they were, executives in work situations cannot get back to work at that same level. They might have to work part-time, or they feel that they can't really take on that large level of responsibility that they were doing before. So those are some examples of late effects. Another example is you give chemotherapy, a particular kind of chemotherapy, which we have to use a lot because it's such a good agent for a large variety of cancers. It's called the anthracyclines group of chemotherapy. It's a high risk of developing congestive heart failure in these individuals many years later. So these are the late effects that we see. Very often we see them, like I said, many, many years down the road. What we've found is that, about a third of our patients really understand that they are at increased risk for these late effects. What we also find is that our practitioners in the community or internists are not really aware of these complications that are happening in our survivors, primarily because they don't see a large critical mass of these patients in their own clinical practice. Pediatric oncologists, adult oncologists are very busy taking care of the acute patients, as in the patients who are currently receiving chemotherapy and radiation. So the group of patients who are far out from their treatment really fall through the cracks in terms of not getting the care from their oncologists and not getting the really absolute comprehensive care from their primary care practitioners. And it is for this reason, to meet that unmet need, we've established survivorship clinics. So what are these clinics? These are multidisciplinary clinics where we have a nurse practitioner, a physician, a social worker, a psychologist, and a dietitian who provide an absolutely comprehensive but very tailored care to the survivors. So we would, for example, do heart tests in order to detect heart failure at an earlier stage only amongst patients who've received the anthracycline chemotherapies, not amongst other people. We would do mammograms in patients who've received radiation to the chest and who are at risk for breast cancer, but not amongst other people who didn't receive radiation to the chest. So very tailored but anticipatory screening in order to detect these complications at an earlier stage and educate the patients, make sure that they understand what the risks are for other common diseases. So for example, somebody who's over 50 years of age, we would make sure that they get colonoscopies or colon screening, colon cancer screening, which would then be folded into that general recommendations or the care plans that I'd mentioned earlier in that particular summary that the patients get. So the screening tests get done, they are reviewed, patients who are found to have the complications are then triaged and sent to the specialists that they can get the care from, and then the patients come back again annually in order to be seen and followed for these cares. A question comes up, if we were to continue to do this in perpetuity, we would have 18 million cancer survivors followed by these survivorship clinics. And somehow this model becomes a little unstable because the demand would be too great for these survivorship clinics to be able to keep up with. For that reason, we need to have a very effective partnership with our primary care practitioners. We need to have them develop a relationship with our survivorship clinic staff so that both of us, the primary care practitioners and the survivorship clinic healthcare providers, can work together to provide the necessary care for the patients so that all the general health promotion can happen with the primary care practitioners, all the specialized cancer-related anticipatory care can happen with the survivorship staff. And at some point down the road, once the primary care practitioners feel comfortable in taking care of the patients, we can have the transitioning of the care happening to these individuals. A question comes up whether the more targeted therapies, the more effective therapies, which really are almost like a magic bullet, which is going to hone in on the cancer cells and not affect the surrounding tissues, how would that affect what the morbidity would be or what the long-term health would be of the cancer survivors? While we had hoped that there would be such magic bullets and there would be such extremely targeted therapy that the surrounding tissues wouldn't be affected, I think we have not come to pass with that particular hope. We are still at a point where the treatments that we're using are affecting other organ systems in unexpected ways. And it is for this reason that we as researchers and as clinicians taking care of cancer survivors have to be very nimble and very anticipatory in terms of following all patients long term so we can learn from them and then apply that knowledge to future generations of patients. You know, in the childhood cancer survivorship world, we're about 2 decades ahead of the adult cancer survivorship world. And part of the reason for that is that, you know, the children had higher successes with their cancer treatment, higher survival rates much earlier than the adults did, and the care of the cancer survivors became a bigger issue at a sooner time than did for the adult cancer survivors. However, we're transmitting that knowledge on to the adult cancer survivors, and we do think the Institute of Medicine and all the other big governmental agencies are recognizing the need for comprehensive long-term care for our cancer survivors. The same survivorship model that we've established for our cancer survivors can now be extended and adopted by a variety of survivors, or I shouldn't call survivors, but patients who are living with these chronic health conditions. And so who are those patients? Those are patients with sickle cell disease, those are patients with HIV, those are patients with congenital heart disease, those are patients with any chronic condition where very often they need to have a medical home where the healthcare providers can really coordinate the care of all of their organ systems, the entirety of their health, and provide complete and comprehensive care to them long term.